Hi and welcome to Pharmacy Internet Radio, also known as Pharmacy IR. I am Kat Collins, your host. I'm a P3 pharmacy student at Campbell University. I'm joined today by my co-host, Dr. Scott Perkins, who is the co-director of drug information and an assistant clinical professor at Campbell University. How are you doing?
Hey, I'm doing well, Kat. How are you?
Doing pretty good.
That's great. We've finally made it to our first inaugural episode of the podcast. Pretty excited. I think it's turned out pretty well.
I do too, very well. Especially since we sort of came up with this from scratch.
Yeah, it's been a work in the making, so to speak, for the past couple months. I mean, we really started this idea when you came and did an OSCE with me in my office. And you finished and you said, hey, I have an idea for a podcast. And I said, great. I have an idea for a video production that we can potentially tie the two together.
Yeah.
And over the past couple months, we've done that. We've worked really hard. So congratulations.
Yeah, I think this is going to be something really useful for students and hopefully also useful for some pharmacists or anyone else out there that's interested in pharmacy.
Yeah.
So we're really hoping to bring the different specialties of pharmacy to students and help them understand really what options they have as they go out there and start their careers.
Yeah. One of the things that we did when we started was we ended up doing a focus group. And some of the feedback that we got when we proposed the idea of having experts on and interviewing with people was that they liked that idea and they wanted to get some more information about, pharmacists as regular people as well, as far as well, how did you get into your particular field and what do you find interesting about that? So
yeah,
I'm excited for it. I think we've got a recipe for success, as they say. So
so today we're going to be bringing you a interview with Dr. Beth Mills. Dr. Mills is an ambulatory care pharmacist with a specialty in diabetes management who works at the Benson Area Medical Center in Benson, North Carolina. So
without further ado, let's do it.
Welcome to Drug Ciphers, where we break down the generic or brand names of drugs to find hidden meanings, or we create our own. The goal is to help you remember how drugs work so you can free up some of that important brain space for other stuff. Repaglinide is an anti-diabetic medication that belongs to the drug class known as the metaglutinides. These drugs work by stimulating the pancreatic beta cells to release insulin. The brand name Prandin is a great clue on how to use these medications safely. Prandin comes from the Latin word prandium, which means a lunch or late breakfast. Ever heard the term postprandial glucose? This refers to the blood glucose spike that you get after you eat a meal. Since Prandin stimulates the release of insulin regardless of meals, it's important to take it only when eating a meal. If a patient skips their meal but takes their scheduled dose of Prandin, it will still stimulate insulin release and puts them at risk of hypoglycemia. So remember, having a prandium, take your Prandin. Skipping a prandium, skip the Prandin. A newer diabetes medication is known as the SGLT2 inhibitors. These drugs work by blocking the SGLT2 transport protein found in the kidneys to reabsorb any glucose that was filtered by the glomerulus. Think of it as a safety net if the glomerulus fails to do its job. Usually, this is a good thing, so our body can use all of its precious glucose to fuel cells. However, in diabetes, we have way too much blood glucose, and it's okay to lose some of it through the urine. All the SGLT2 inhibitors have the same suffix, flosin. We can use this to help remember how these drugs work. Just remember, the flosins allow glucose to flow through the kidneys and out into the urine. We can also use this hidden meaning to help remember some of the side effects of the medication. People who take flosins have to urinate a lot. This is because the glucose increases the osmolarity of the urine, which draws water into the urine, producing a much higher volume. So remember, patients on flosins have a heavy flow and need to go. That's it for our drug cipher. Hello and welcome back to our podcast. I'm Kat Collins and I'm really excited today to have Dr. Beth Mills with us. Dr. Mills received her PharmD from Campbell University in 1998 and went on to complete a primary care residency with a diabetes management focus at Wilson Community Health Center. Today, Dr. Mills is a clinical assistant professor for pharmacy practice
And she is also the residency director for the PGY2 ambulatory care residency with Campbell University. In addition, she is a board-certified AmCare pharmacist and a certified diabetes educator at the Benson Area Medical Center. Dr. Mills, thank you so much for joining us today.
Thank you. Thanks for having me.
So we'd love to talk a little bit about sort of just your life, how you came into pharmacy, how you grew up, and what brought you to the job that you do now. So
okay. Well, I was born in North Carolina, and but we moved around a lot. So my dad was in pharmaceutical industry, and so we moved every 2 to 3 years. And I've lived all over the United States. I've lived in Kansas. I lived in Illinois. Lived in Puerto Rico for a little while. I got a nice broad look at the United States. But we did eventually land back in North Carolina, and when it was time for me to go to college, I originally thought I would be a math teacher, and my goal was to become a high school math teacher. So in undergrad, I focused on math. And so after about a year, my dad said, you know what, I think that pharmacy would be a good career for you, because he was in the industry and he worked with a lot of female pharmacists, that he thought it would be a good career for a female in general. So he recommended that, and I applied at Campbell and got in. So I only applied to one school, and that was Campbell, because I was already here and I loved it, and I lived in Garner, so I was commuting, and I also had met my husband at the time and was really hoping to stay close to home. So then that was in 1994 that I got into pharmacy school. So
Great.
That was my little trip around the world.
Well, tell me a little bit about who you were as a student.
Oh, Lord. I was the stress wad. Everything was about the grades. I feel like I worked around the clock. I didn't sleep much. And I actually worked 3 jobs while I was in pharmacy school, because I waited so long to go to college. My parents felt like that I kind of gave up my right for them to pay for me to go to school, so I was responsible for my whole entire education. Plus, I had 2 brothers that were in college, and my mom went back to school at the same time. So my dad was like, I've got 2 in college, and my mom was at Meredith, so that cost so much money, and he said, you're just going to have to do it on your own, which I did. They did let me live with him, so that was nice.
Yeah.
So I worked as a technician at Walmart, part-time in the evenings, and then every other weekend. And then I also worked at Wake Med Cary as a technician every other weekend. So I worked every weekend as a technician somewhere. And then I also taught organic chemistry lab here. So I had 3 jobs. But as a student, as far as what I was involved in, I was very heavily involved in APHA, ASP. I had a regional position, so I was the regional mid-year meeting coordinator, I guess. And so the year that I was in school or most active in ASP, it was our job or our turn in the region to host the big, huge mid-year meeting. Oh, wow. And so I coordinated the whole entire meeting. We hosted it. We had it in Raleigh. You know, the whole region came, but I had so much help. We got everybody recruited. We had a huge team together, and it went off without a hitch. It was very stressful, but it was really cool.
I'm sure that was rewarding.
Yes, it was very rewarding. Other things, I had leadership roles, and I was the president of the class 1 year, vice president of the class 1 year. I was involved in student government, involved in SSHP. I was a delegate at national meetings a couple of times. I went to all the meetings, all the meetings. Yes, we had a lot of fun.
It's a good experience to get to go to those and see how it all plays out.
Yeah.
Cool. So welcome to the Drug Limerick Challenge. This is a short game show where we invite a guest on. Today we have Sarah Jones. She's my 4th year pharmacy student on my rotation. Welcome, Sarah.
Thank you. It's good to be here.
Yeah. So we ask our guests to guess a drug based off of a limerick that we're going to read. And these are limericks that are sometimes created by me, sometimes created by our fourth year students on rotation. Today we've got an especially fun limerick. It's my favorite one. Got to start off strong. So I'll read that to you in just a minute, and you're going to have the awesome opportunity for a coffee-infused prize from our coffee vendor downstairs. So get excited. How are you doing today, though?
Doing very well, thank you.
Excellent, excellent. So you're on rotations.
Yes.
So you're on DI right now. We're halfway through.
Yes.
You just finished some residency interviews.
Yes, I did.
What are you looking forward to before graduation? What before besides graduation? What are you looking forward to going into next?
Well, definitely match day. I think that's slimming for all of us, that are applying to residencies,
Yeah.
ready to kind of see what those results are, and ultimately, just trying to figure out, where exactly I'm supposed to be as far as jobs in general.
Yeah.
And so I think that's probably what I'm looking most forward to is kind of that next step
Sure.
after graduation.
So you're looking forward to one of the most nerve-wracking days of all time. I get it.
I don't do well with patience, so just at least knowing either way will be good.
Get through it. I love it. All right. Well, are you ready for this?
Yes.
I'm ready as well. So I'm going to go ahead and read the limerick. I'll give you a couple minutes to think about it and think about what it might be. If you have some questions, you can ask me a question. I think you got this, though.
Okay.
I believe in you. All right. 10, 15, 20. How does it rank? Kinetic doses, a G-pause tank. 10 per min, go slow. C. diff, PO. Mud kills MRSA, so give them... And then the drug name rhymes, so we'll do it one more time. 10, 15, 20, how does it rank? Kinetic doses, a G-pause tank. 10 per min, go slow, C. diff, PO. Mud kills MRSA, so give them... And it's blank.
Is
Rhymes.
the answer... Wait.
It's not a full drug name. It's an abbreviated drug name. So we'll break it down. It's really hard to do this when you don't get to see them.
Yeah, so, I was thinking initially Vang.
Yeah.
Okay.
It's Vang.
Okay. I was like, but Vang doesn't rhyme with MRSA, so I was trying to
So it rhymes with the first two. So let's do it one more time now that you guessed it right. Good work. You get a wonderful coffee flavored prize.
Yes.
Or you don't like coffee. So
It's okay.
You're not a caffeine person, so we'll do something else.
Yeah.
I like that. So 10, 15, 20. So I'm thinking of 10 to 15, 15 to 20 are typical
exactly.
bank troughs. And then we're thinking, and then the next line is, how does it rank? I guess what I'm trying to do there is to say, like, well, based off the severity of our infection, the different types of infections, so how does it rank within these different trough levels? Kinetic doses, it's a G-pause tank, so it's very strong against gram-positive bacteria.
Right.
We typically, a lot of times, give it, according to the manufacturer, about 10 per minute. We go slow typically to avoid red man syndrome. For C. diff, we give it by mouth. C. diff, PO. Used to be called Mississippi mud. And then, so the last line is, so give them Vanc. So Vanc is obviously sometimes an abbreviation for vancomycin.
Right.
So good job.
Well, thank you.
Congratulations. Awesome. Successful. Well, thank you for watching this segment on our podcast, and we'll get you back to the show.
Hi, and welcome back. We're here with Dr. Mills. Dr. Mills, we'd like to get a little bit into what you do now, the aspects of your current job, and sort of your path from residency to your current position.
Okay. So when I finished my residency, there were not a lot of ambulatory care jobs available in the state of North Carolina or really in the United States. It was fairly new concept. So I had a pretty extensive history with Walmart already. I had worked there as a technician and then also as a pharmacist, moonlighting while I was doing my residency. And so I just went ahead and stayed on at Walmart, which I loved. I stayed there in many different, I moved around from store to store, but I finally landed in Knightdale as a pharmacy manager, and I was in that role for about 6 years. While I was there, I realized that I missed the clinical training that I had acquired, and I wanted to do more clinical work. And I was very fortunate to meet a good friend of mine, Michelle Jacobs, who she had just started her own business. She was one of the very first CPPs in the state of North Carolina, and so she started a business where she went into doctors' offices. She would go into a doctor's office one day a week, and they would have patients scheduled to see her for whether it be diabetes, lipids, anti-coag, whatever. But she became so busy and acquired more doctor's offices than she could handle. So she brought me on, and I was able to do that one full day every other week. So Walmart was gracious enough to let me work my schedule out that way. I did that for about a year and a half, and then a position came available at an independent pharmacy in Fuquay-Varina. It's called Medicap Pharmacy at the time, which is a franchise. This one was owned by Cardinal Health, and so that was actually better because they let me come in and basically do whatever I wanted. So what I wanted to do was my clinical stuff. So I would do all the traditional dispensing parts of the job in the morning, and then I started a clinic, diabetes specialty care clinic, and also an obesity management clinic. And so I would schedule patients in the afternoons. I had advanced community pharmacy students from Campbell who would come, and they would help me with my patient load. We started a vaccine administration, so this was when vaccines were just getting, pharmacists were just getting ready. Yeah, pharmacists were just getting their feet wet with administering vaccines, and MTM. So we had a lot of new clinical roles that we were trying to take on. But then Cardinal sold my store. So yeah, I was a little upset about that, but then I ventured out to something that I wasn't very comfortable with, and that was hospital pharmacy. There was a position available, and it was ambulatory care, but you still had to do a lot of inpatient work as well. So I became the ambulatory care team leader at Rex, and it was mostly anticoagulation. So all I knew was diabetes and weight loss and nutrition, and there was none of that in this new role. So I had to learn a whole new clinical trade, I guess, whatever. I had to learn new skills, and so I was there for about 3 years, and then the position at Campbell was posted, and I thought that would be good for me.
Back to your roots.
Well, yeah, because I always wanted to teach anyway, and so I thought this would be a win-win that I would, plus I knew that I was going to be able to manage diabetes in this new role, and so, that was where my heart was anyway, and now I can do both, or all of it. I can do weight loss management, I can manage anticoagulation, I can manage diabetes, and now we've just recently taken on, we perform all the pulmonary function testing in the clinic, which is, we do a lot. So we do all the spirometry, we diagnose COPD, asthma, we manage that now too, so we have a lot going on.
And you've been at the Benson Area Medical Center for about 5 years now?
6 years.
6 years.
Yes.
Oh, wow. So what are the main, well, you've sort of gone over the main features of your job, but what do you think makes your practice site unique from other AmCare pharmacists' practice sites?
Well, if I were to compare to some of the main ones that I know of, I would say that we're a little busier. And that's probably my fault because I don't say no very well. And so we have a very busy patient load. I am in clinic all day on Tuesdays and Thursdays and 2 half days. So in that time period, we jam pack it as full of many patients we can. And right now, to get on my schedule at the clinic, we're booked out till May.
Wow.
So if patients call and they cancel their appointment, it's almost impossible for me to get them in any sooner than 3 months down the road or 4 months down the road because we are so busy. I think that what's unique too is our relationship with our providers. Our providers, we do something called shared visits, which not all the clinics do that. So that means that we schedule patients with us and the provider at the same time, or back to back is a better way to explain it. So the patients will come in and they will meet with us, and then we actually build the whole entire visit. We do all the documenting. We assess labs. We assess their point of care results, and then we make a plan. And then we will hand off to the providers, and then the provider will go in, and they basically just go in and bless the visit. Yeah. They just go in and say, yeah, well, whatever she said, that's what we want you to do. Okay. And the providers love that.
Right.
Because it helps them move along through their schedule, because they have a quota to meet every day. And if, this one patient could have taken 30 minutes out of their time, when now it's only going to take 5. So they can pretty much see more patients in the day if we have a lot of patients on their schedule for that day. And I think another thing that's really unique is the fact that we do perform all the spirometry. Not a lot of M-Care clinics actually do that part of, and some people might say, well, I don't want to do that. Anybody could do that. But it really helps you understand what those values mean, FEV1 and FVC, and how to evaluate that and interpret that, and then what to do with those. And so instead of just looking at results, you're actually watching the patient give those results.
Yeah. More hands-on.
More hands-on. The students love it.
Yeah.
Yeah.
So what are some of the challenges that you think ambulatory care is facing today, or diabetes management, or any of the conditions that you treat?
For diabetes specifically, I think the biggest challenge right now is the rising cost of medications. Mm-hmm. The insulin, and I'm sure you've seen it on the news lately about how it's just the astronomical prices. The prices of insulins have gone up and up and up. Patients are having to skip doses to make their insulin stretch longer. And one insulin can cost up to $1,000 in 1 month. And we have patients on multiple of those. We have them on a GLP-1 receptor agonist, and we have them on a basal insulin, and we have them on all these other very expensive medications. We used to say that a patient would spend about $2,500 a year on their diabetes supplies and medications. That's probably $10,000 now or more. So, in just 20 years, that has gone way up. And it becomes really a challenge, because especially if you have patients that don't have insurance, or if you have patients that have insurance but they have a really high deductible.
Sure, yeah.
That becomes a challenge. I think another challenge is just the sheer number of medications that are hitting the market right now, and that I know are in the pipeline. Mm-hmm. So where physicians felt pretty comfortable managing diabetes before, they are relying on pharmacists more and more. So it's not so much a challenge for us, but I think just for the care of a diabetes patient in general, that they're not able to keep up with all of the drugs. I mean, there are so many drugs on the market in so many different classes, and then just in each class, there's so many nuances to all the different drugs. Maybe this drug could, might cause acute kidney injury, but this one really doesn't. So, that's good for us, because we are the drug experts, obviously, and so we can know the ins and outs of all of those medications and help them out. But the more drugs that come on the market, it's going to be even more challenging.
Sure, yeah. How do you integrate on the healthcare team, and sort of what do your colleagues come to you the most for?
Besides diabetes and weight loss, drug-drug interactions is the number one question that I get. And so I just had 2 students start yesterday, and we were having orientation in the little patient education room. And no lie, I had 3 providers standing in line with their computers saying, "Can I ask you a question?" So most of them are drug-drug interaction, and I would say QT prolongation and serotonin syndrome are going to be the top hits that we get. The other thing is going to be on just drug therapy for psych stuff. So probably depression and bipolar disorder are going to be number 3 and 4 after diabetes and obesity. So because they feel so uncomfortable with it, and they feel like they just need confirmation that they're making a decision that doesn't seem really outlandish or something,
Sure. Yeah.
So they're like, am I going to kill my patient if I do this? They just want you to say, no, I think it'll be okay.
Yeah.
And they get all of these pop-ups in the system that we use that make them feel like every drug interaction is actually gonna kill their patient. Right. So, it's nice for us to be able to say, okay, well, I know it says it's a drug interaction, but really here's what the data shows. And so, we try to always go to the evidence and say, there was a study that showed that it increased the concentrations by this or whatever.
That's great. What drugs, I guess you've spoke a little bit about drugs in the pipeline, what drugs are on the horizon that you think are just going to change your practice, if any?
I think that, there's some oral formulation of GLP-1 that I think are going to be, it's not necessarily change my practice, but I think that we won't have to do as much training for injection technique and things like that. There is an oral insulin in the pipeline, so I've not heard that it's going to be. I have not heard that it's that successful so far. So we'll see. That would be a game changer if depending on what type of patient would be a candidate for that. So type 1 probably not. I would think. We do have the inhaled insulin, and we thought that was going to be a game changer, but that
was a big letdown.
It was a flop. I think that it's going to be more about the technology instead of the drugs. So with the new continuous glucose monitors and what we call the flash glucose monitoring system. So you have the continuous ones that read continuously, but then you also have the one like the Freestyle Libre where it will, if you scan it, and it'll flash a number, and that's your glucose at that time, but it doesn't continuously read. Those, I think, are going to be a game changer, and the insulin pump technology is really, they're really getting advanced, and we're getting closer and closer to not really a true artificial pancreas, but as close as you can get.
Something close to it.
Yeah.
I'm going to put you on the spot here. If you had to create a formulary to treat the patients that you see, and you could only pick 5 drugs, what would you pick?
Is this for diabetes management?
Sure, we'll just go with diabetes.
With diabetes management. Does this mean that the medications are affordable for the patients?
Well,
like we're giving
cost
them,
is not an issue.
Cost is not an issue. Okay, well, I definitely would have to have, insulin would have to be on there. GLP-1 receptor agonist would definitely be on there just because of all the cardiovascular data that they have. And definitely would not be a TZD or a sulfonylurea. All right, so I got insulin, I got GLP-1. SGLT2 inhibitors are probably, they're taking, a big chunk of the market right now, and they actually are showing a lot of benefit, and they have positive cardiovascular data, so we'll probably go with that. Metformin, obviously, would have to be on there.
Number 1.
Yeah. I think we could live with those 4, probably, and be good.
Foregoing a 5th. She's confident in those answers.
I'm confident in those 4, and those answers. Yes.
All right, so just to finish up, I want to ask a few questions. And this is a little selfish of me because I do have you on rotation. But what advice do you have? So what advice do you have for students interested in that specialty? And what kinds of things do students really struggle with when they come on your rotation?
Okay, so what do students struggle with the most is probably knowing the drugs. Just because there's so many, and however, the American Diabetes Association, their newest standards that they've just released, just released them in January, they put out a new algorithm, like a decision tree, that is phenomenal. It's I used to say go to the ACE for the drugs, but go to ADA for everything else. Well, now the ADA, their dosing decision algorithm is far superior now, I think, than the ACE guidelines, so I don't even go to those anymore. And they really guide you onto a drug therapy. If the patient has this, then you're going to choose this and this. But if they have heart failure, you're going to choose SGLT2 inhibitors. But let's say they have, poor kidney function, then you're going to have to go here. But if cost is an issue, then you're really only limited to these 4 over here. So it really guides you. And of course, GLP-1 receptor agonists and SGLT2 inhibitors are almost in every category. So you know that if you're going to come on rotation with me, you better know those,
Sure.
right? And you should know metformin, right? I think that the other thing that students struggle with is we see a lot of advanced diabetes patients, meaning that they have type 1, they're on an insulin pump, or they're on multiple injections per day, and we have to do a lot of titration and adjusting and calculating the rule of 1800 and the rule of 500. And so all of that stuff comes barreling back in, and the students are a little overwhelmed. But I think that that's the biggest issue. I think that I've been pleasantly surprised at how well students do counseling patients. I think we must have done a really good job of, getting students prepared to teach a patient how to administer insulin, how to draw insulin out of a vial with a syringe, or how to use an inhaler. And most of my students seem to feel very comfortable communicating with patients and with providers. So I think the biggest hurdle is just knowing the drugs and the pathophysiology behind that. As far as how to prepare, study, no, I have a wiki page, and so before you come on site with me, I will share that with you, and on there I have resources, I have links to websites, I have articles that you should read, I have pretty much everything to get you started. But really, if you want to be prepared now, you're starting being prepared now, I would just say review the guidelines. Yeah. Everything that we do is evidence-based, or we try to make it evidence-based. Recall how to write a poem, because you will definitely write some of those. We do 3, so each student has to do 1 every week, up to 3.
Okay.
Yeah, so we do a lot of evidence-based medicine.
Well, that's always good. That's what we strive for.
Yeah.
Well, thank you so much for joining us today. It was great getting to talk about
Thanks for having
your
me.
practice, and thanks for tuning in.
Thank you.
Hello, my name is Evan Lucas, here to share with you a clinical research moment for you today. In this segment, we'll be going over some pertinent literature review and just some good old-fashioned journal club. So let's jump right in. Today's journal is Diabetes Care, and we're looking at the February 2019 issue and a little study that looked at the class-wide cardiovascular effects of the SGLT2 inhibitors for diabetes mellitus and type 2, and specifically dapagliflozin. So let me give you some background, because this is a pretty cool study, and the way they were able to process and work through the data was really fascinating. So in 2008, the Centers for Drug Evaluation Research, basically within the FDA, issued a guidance saying that all new approved diabetic meds would have to have new data supporting their cardiovascular risks and benefits. So that meant that all these studies for new drugs that came out past that time from 2008 onward had to have millions of dollars of new data to support their claims and to help show that they were that they were efficacious on a cardiovascular level. So one of these studies, which was conducted again by all different manufacturers, was done by AstraZeneca, and they looked at one of their products, exenatide, and its effects on cardiovascular composite outcomes. It was called the EXCEL study. So someone at AstraZeneca, I guess, had the bright idea, and they said, well, if we can do this we were spending all this money, millions of dollars to do this study, the EXCEL study, then couldn't we take some of the patients in that study and maybe leverage some of that into another study for another product that we have called dapagliflozin, or Farxiga. And they were able to do this, and what this study basically was they were able to say, okay, let's get more bang for our buck, and we're going to take the placebo arm of this other trial, and we're going to break it up and be able to see that maybe we could find some effects and some subclinical effects within this subpopulation by doing a post hoc case control analysis. So other research previously had shown cardiovascular benefits. So like the IMPA-REG trial came along in 2015 and showed benefits for empagliflozin. So based on the previous literature and where they were today with all this data from the EXCEL study, they were able to start making a transition and see if they could use what they had to get what they wanted, which was more data and more information on cardiovascular risk and benefits of their drugs. Let's look at the design of this trial. So again, it was a post hoc analysis done in a case control manner of the placebo arm of the Excel trial. And the placebo arm of the Excel trial was not just like a sugar pill that was given to patients. It was an active control because we don't want people with diabetes to not have the medications that they so desperately need. So of the 7,396 participants in the placebo arm, 786 used an SGLT2 antagonist. 385 of those used dapagliflozin. So what they looked at was 3 different endpoints here. They wanted to see the time to first composite mean adverse cardiovascular event. So these were 3 endpoints bundled into one. So we had cardiovascular death on the one hand, non-fatal MI on the other, and finally non-fatal CVA or stroke. So death, heart attack, stroke, all 3 of those mixed into one, your cardiovascular endpoints. And then the second endpoint was the time to the first composite all-cause mortality. So did someone die and why, basically. The third one was a change in GFR. So they looked in using the MDRD equation to estimate patients' renal function and saw how that changed and if they could predict or show some sort of treatment effect based on that change. And there was other exploratory endpoints pursued, which we won't cover here, but you're welcome to pursue at your leisure. So patients that were in the placebo group but not on an SGLT2, those served as the matches for the patients that were. So let's look at some of the results of this study. The 3 endpoints we're going to look at are consistent with what we talked about earlier. So major adverse cardiovascular events is our first one. So let's look at that. There was no statistical significance found among the groups. So basically, there was no significant difference between those who were on an SGLT2 or on dapagliflozin and those that were not in terms of their cardiovascular risk. Now, they reevaluated this endpoint later in another analysis and looked at people that had prior cardiovascular disease versus those that did not. When they did this, it parsed out a little bit differently, with significance emerging in some groups. So they saw in that analysis that significance was seen when people were on an SGLT2 versus not and did not have cardiovascular disease. So the next endpoint was all-cause mortality, and we did see some significance there. It was reduced by 0.48. So the hazard ratio was 0.48 for people that had any SGLT2 use versus no SGLT2. So when you used an SGLT2, you had a less likelihood of reaching an all-cause mortality endpoint than you would if you were not on an SGLT2. And both an unadjusted and an adjusted hazard ratio showed the same statistical significance. And this significance did disappear, though, when dapagliflozin was analyzed by itself. So the third endpoint was our renal endpoint, and they looked again at that GFR change. So this is more of a treatment effect that was reported. And there was a treatment effect of an increase in 1.78 points per year if you were on any SGLT2. And also on dapagliflozin alone, you would improve renal function by 2.28 points per year. Both of those showed statistically significant p-values. Let's look at some of the conclusions for this study. So the pros of the study was that it showed a class effect for all SGLT2s in terms of their cardiovascular benefit, that there may be something to be said of their cardioprotective and possibly renoprotective effects. Renal benefit was shown to be consistent among the prior research as well, and cardiovascular protection was shown in primary prevention, meaning that those without the cardiovascular risk, what we talked about, that they would have a cardioprotective effect on the SGLT2s. So that may have increased benefits and increased awareness for that in the future in practice. The cons of this study was that these cohorts that were matched were smaller than real life and were smaller than some of the studies that had been done. The strength of evidence may not be as strong because you have some time bias and some imbalance in follow-up. So in summation, the SGLT2s appear to have these class-wide cardiovascular and renoprotective benefits, especially in those who are younger with no prior cardiovascular events. More studies could be done to analyze this in the future, but this is very clinically relevant and should be considered in patient care. And on a clinical research note, this study really shows that how companies are able to use this new FDA kind of big data environment that we have to basically find a current trial and use it to provide research about another future trial, and therefore save money and time without jeopardizing patient health. So for your clinical research moment today, I'm Evan Lucas. Thank you.
Oh, well, that's the first episode in the books. How did you think it went?
I thought it went pretty good. Yeah, Beth was gracious enough to come on and be our first guest. And it was very interesting to hear about her story getting into pharmacy and kind of working initially with diabetes and then branching out what she does to where she's overwhelmed a lot. But I wouldn't imagine anything less with Dr. Mills. When she gets into something, she wants to continue to try and do her best. So it was great.
That's how I think all of us in pharmacy tend to be.
Yeah, absolutely.
Overachievers.
Yeah, well, we're interested in hearing a little bit more about our listeners and our viewers and maybe what we can do in this podcast to improve it. So there's a survey link. It's actually in the description below the video. So please take that, fill that out, and tell us what we can do to potentially improve the podcast, other things that you might want to be, that we could potentially include in here as well. So that would be wonderful. So.
So please join us next month for another immediate release.